having me here for another session. Hope you don't get tired of listening to me. So this topic on this session is going to be on carotid interventions, and I was asked to give an update on what it is in 2022. So I'll quickly go over some of the new things that we have in carotid interventions. Here are my disclosures. So we've had carotid stenting available to us for a long time now, but there's been a lot of challenges as far as data. There's been a lot of advances in the technology, but it's been limited primarily by stroke. And so when you think about the stroke, again, it's a small percentage, but nonetheless, it's been the limitation in progressing carotid artery stenting. And if you think of stroke during a carotid intervention, there's two different areas that you could potentially get a stroke from. One is from aortic embolization from the path of the sheath or the guide. So if these are patients that have extensive calcifications or atheroma in the aorta, you can embolize from the aorta up into the cerebral circulation. Or it's a lesion embolization from just crossing the lesion in the carotid space. That's from the catheter or the device manipulation. And so how can we affect this, or how can we improve the outcomes with carotid stenting? And so these are areas that have been looked at, and that's what I'd like to focus my attention on today. So to avoid aortic embolization, the question is, can you change your access to try to limit the risk of aortic embolization? And then to reduce lesion embolization, can you change the technique in how you do the procedure to reduce stroke? So let's talk about access first. One of the new innovations in doing these procedures is that you can do carotid interventions transradially. A lot of procedures have evolved into using the radial access for interventions, both on the coronary side and even peripheral interventions, but recently also for carotids. So I'll present a case quickly. This is a 73-year-old male with history of hypertension, hyperlipidemia, had ischemic cardiomyopathy, EF of 30 to 35%, lung disease, diabetes, multivessel coronary disease, had PCI already, now presenting with carotid stenosis. Ultrasound only revealed moderate left ICA stenosis of 50 to 69%, had a peak systolic velocity in the proximal ICA of 174, and diastolic velocity of 50, but the CTA of the neck reveals severe stenosis at 75% of the proximal left internal carotid artery and complex atherosclerotic plaque with ulceration. So here's a CTA, and again, as soon as you see this, you'll understand the calcification in the aorta itself around the arch, and then you see the eccentric lesion in the left ICA as well. So this was actually done radially to try to avoid manipulation of the sheath in the aorta. And so what you'll see here is a railway sheathless guide system that we are advancing from the right radial approach. And the technique here is to really come down to the aortic valve and then go back up into the left internal carotid artery. And so you'll see the guide sitting here. It's an Amplatz guide with a wire that traverses very easily along the aortic arch up into the left internal carotid artery. And here's now with a sheath that's traversed around that loop all the way up and showing the calcified eccentric lesion, right, focused, very discrete in that left ICA. Here are the intracerebral angios demonstrating adequate flow without any other anomalies. And here's the wire crossing. This is a filter wire, so we use distal embolic protection for all carotid interventions. So this is a 7mm AngioGuard filter that traverses the lesion and is being deployed above the lesion in the internal carotid artery. And then subsequent stent deployment that you'll see on the right panel here. You'll see that being deployed. It's a self-expanding stent. across the lesion. And then final post-dilation of that stent with the final result here with brisk flow and preserved intracerebral flow. So showing that you can do these procedures from a transradial approach. And that's not just a single case. This is a paper that was published in CCI, the Sky Journal in 2012, looking at transradial carotid interventions. And you'll see that the risk or the adverse events are extremely low. You still see that 3% TIA risk. Radial artery occlusion was the primary risk that you saw with these procedures. The newest technique for as far as access is the transcarotid access for carotid interventions, and this is TCAR. I'm not sure if you're doing this in Bangladesh, but this is direct carotid access in the carotid artery, and then utilizing this en route system to reverse the flow from the carotid artery back into the venous system so that there's no distal embolization because the flow is reversed into a low pressure system in the vein. And so all the flow is going retrograde this way into the femoral vein, and that way no embolization happens here. And this system itself has a filter in it, so anything that's coming retrograde is filtered out before it's pumped back in. The early outcomes, when you look at this is the Roadster 2 study that was done, showed significantly improved results compared to carotid endarterectomy or carotid stenting. So this was actually compared in the next slide that I will show you, but look at the risk here in the intention to treat arm and the primary arm. You'll see that the adverse event rates are extremely low, sub 2% in most of those events. And then if you look at the registry comparing TCAR with carotid endarterectomy, you'll see a pretty similar result in TCAR compared to endarterectomy. And so again, a significant improvement. And then finally, we talked about improving the technique in how we do these procedures. And one of the ways we've improved that is by doing robotic interventions. And here's a 73-year-old gentleman with history of coronary disease, had coronary interventions with drug-eluting stents, heart failure with preserved EF, hypertension, and a prior stroke with atrial fibrillation, hyperlipidemia, that was referred for right internal carotid artery stenosis. Carotid duplex showed greater than 80% right internal right ICA stenosis. This we did robotically, and so we have a robotic arm. It's a CorePath GRX system that has a robotic arm on the cath table, and everything else is controlled from this console with joysticks. It's essentially like playing a video game. And so here is the catheter, again, doing the same way, going from a radial approach, going around the aortic valve in the non-coronary cusp and advancing the sheath up into the right internal carotid artery this time. And what you see here is a selective injection, which shows this really ulcerated, nasty lesion in the right internal carotid artery. Here's a robotic crossing of the lesion, so this wire is being advanced robotically here. You see that it's a very systematic advancement with micro movements. And here's the final result after stent placement across that ulcerated lesion. This is the paper that we published on that case. This was the first robotic carotid intervention ever done that we published in 2020. And so it comes down to, again, looking at the lessons that we've learned from CREST and prior carotid artery stenting, and by improving access and improving techniques, can we do carotid artery stenting in low-risk patients? Whew. So carotid interventions continue to evolve in 2022. Technological advances and smaller device sizes will limit embolization, and robotic-assisted interventions and AI-mediated algorithms will likely improve clinical outcomes. Okay, and with that I'll stop and I'll open for any questions. Thank you. Sorry about that.